So we will get started now. Hello everyone and welcome to our latest edit of the Loddon Mallee Integrated Cancer Service Sexual Wellbeing Community of Practice. Can you flick to the next slide, Krista? Thank you. Before we get started today, I would just like to acknowledge and extend my appreciation to the Dja Dja Wurrung people, the traditional owners of the land I'm on today, and pay my respect to the leaders and elders past, present and emerging. And thank you for joining us today. So my name's Tara and I'm an exercise physiologist by background and also a project manager for LMICS, the Loddon Mallee Integrated Cancer Service. And joining us today, we have Laura Lee, Lisa Carson, and of course, Krista Phillips, who will be presenting as well. I just note that if you are able to, and if you're comfortable to have your camera on, that would be really great, just to help put a face to the name and increase the discussion. And if you have any questions, just pop them in the chat box. Krista will be monitoring that and we'll try and get some good conversation from today. So today I will be the friendly timekeeper. I've got my watch set to efficient meeting mode, so please don't worry if I yell a little bit. I'll try to be gentle, but if we are drifting off track, I'll just give everybody a friendly reminder. So the first presenter we have is Laura Lee. Laura is a psychologist and sexologist with over 17 years experience in clinical practice and coaching. She is the director of Blue Space Psychology, where she provides individual psychological and sexual therapy. In addition to this experience, she provides supervision, professional consultation, and workshops to healthcare providers. She also offers online courses, education, and coaching, and is a highly sought after speaker and trainer. Her work has been published in the Journal of Positive Sexuality, where she explored how communication impacts sexual desire and satisfaction. And her extensive experience, academic research, and practical insights, coupled with her warm, authentic communication style, sees that she's a highly respected voice in the fields of psychology and sexuality. So thanks, Laura.
Thank you so much. Tara, how long do I have? Because I don't want to be yelled at. Is it 20 minutes?
You've got 20 minutes plus
20 minutes.
Time.
Yeah, that's what I'd worked to. That's absolutely fine. Thank you for that warm welcome. Thank you all so much for having me. Krista, are you controlling my slides? Is that what we're doing? I just want to make sure I'm across that administration.
Yep, just give her a nod when you're ready.
Great. Okay, wonderful. Thank you. I also want to extend my own kind of acknowledgement because I am coming to you today from beautiful Wurrung country, which is kind of the Geelong and Surf Coast area of Victoria. So I always just like to acknowledge that I am deeply grateful to live and work and play in this beautiful part of the country. Next one, Krista. I want to take a moment here to just very quickly add to that introduction and also just to kind of let you know of a couple of additional affiliations that I have and groups that I belong to that I am really deeply passionate about. So one of the areas I do some work is in gender affirming healthcare. So I am an AusPath verified provider and I provide assessments for people accessing gender affirming care. And likewise, I'm a verified provider with Size Inclusive Health Australia. So these are in addition to my memberships and registration as part of being a psychologist and sexologist. So what we will cover today, if you can click through, that would be wonderful. But what we will cover today is basically an overview of body image and cancer, and then that intersectionality of sexuality. I will move through that section relatively quickly because the main thing I want to get to today is to really arm you all with practical strategies. I think one of the things I want to say from the outset is that I'm really aware that issues of body image and sexuality can often be kind of sidelined in cancer care because there's so much about cancer treatment that is about side effects and what is going to change and what is going to be hard, rather than how it's going to actually feel to be in my body. So that's really what I want to emphasize today, and the message I want to send you all away with. So if we can have a look at the next slide, I just want to very quickly frame up what I mean when I use the word body image, because body image is not just about how my body looks, it's about the relationship that I have with my body. So this is how a person experiences their body, feels in their body, the thoughts they might have about it, the beliefs that they hold about it, the emotions they have about it. And we can, of course, hold multiple body images, if you like, at once. And it's incredibly changeable because that relationship with our body is always occurring in a context. And I'm sure you can think about this even in your own life, because, of course, we all have a body image. I'm sure you can think of times in your own life when that relationship with your body has felt more peaceful or less peaceful, or more challenging, or whatever the case may be. And I'm sure you can think of the different contextual components that were impacting that at the time. So it's a highly variable, lifelong relationship. And when I think about that through the lens of body image being a relationship that I have with my body, and I overlay how cancer might change that relationship and might shift that context. I mean, I'm sure I don't need to tell you all of these, but if I think about the physical changes that can occur that can impact how my body looks, feels, and functions, and whether it still does what it's always done. I think about that also through the lens of hormonal changes and how that might show up with regards to functioning. Here I start to think about sexual functioning, like changes in lubrication or erectile functioning, changes in how I experience my desire or my want for sex. That you can start to see how like that broader context can be really profound. And finally, that emotional identity shifts, this sense of like a loss of control and a sense of grief, perhaps, which I'm going to talk a bit more about on the next slide. Let's actually look at the next one, because I really like to think about all of the work that I do anyway, but particularly in this space through a trauma-informed lens. Because if I think about this and overlay this idea of body image, I'm thinking about the body as a site of trauma. There is, of course, medical trauma. You know, it's invasive, and there's a loss of bodily autonomy and a loss of predictability, and that medicalization of the body. And that combined can lead to this real dissociation or disconnection. And so I think about this sense of numbness that people can sometimes describe, or disconnection. I feel foreign in my body, or like my body isn't mine anymore. And I don't want to labor this point too much. It'll be a whole separate presentation, but that, of course, can at times have a very protective element to it, a very protective component to it. So I'm always thinking about that here too. When I think about grief, I think about the fact that cancer disrupts how people have known their bodies to be. So now their body feels unpredictable, medicalized, painful, unrecognizable. It looks different, it functions different. So there is grief for the body that they maybe had, but also maybe the sex life that they had and the identity that they had. And sexual well-being isn't about sexual functioning. The actual act of sex is a relatively small component to how people appraise their sexual well-being. And we know this to be true because things like frequency of sex are not remotely relevant to how people appraise their general sexual well-being in the research. So the shift in identity there can really impact people's sexual well-being, which is such an important part of mental health. So the healing here is not just physical. There is this kind of psychological mourning, if you like, exists in the form that it used to. If we can move to the next slide, there's kind of three key areas that I thought about when I thought about sexuality after cancer, and when I was thinking about what kind of strategies I wanted to arm you all with today. The first is around the functioning piece, like how my body responds, right? So we're thinking about the very physical there, like as I mentioned before, erectile functioning or vaginal dryness, but we're also thinking about things like there might be pain that wasn't present before or is different to before. Arousal and libido are also part of functioning and responsiveness, and they may have shifted. There's also here a confidence piece. So we're thinking about a fear of rejection or like a shifting in sexual self-image, which then, of course, leads us into relational factors. There can be partner anxiety, there can be these shifts to caregiving. Something I hear from my clients a lot is this idea that a partner, well-meaning, really well-meaning, might be very aware that things are difficult for their partner and might take this stance of, I'm here for you, come to me when you're ready. I'm fine, no pressure, no rush, come to me when you're ready. And that's incredibly well-intentioned, but it's also incredibly lonely. Now this person is over here feeling like, oh, now I am the one with the problem. I am the one that has to shift and move towards, and it can be really distancing. So it can be really useful to be thinking about how can we have conversations that move people towards each other and explore what our body does like. So much of a medical process and cancer treatment is about all the things my body can no longer do or doesn't like or doesn't feel good, and reconnecting to what does feel good is really important. And I've got a tip for you about that in pleasure. And finally, the interplay between body image and sex is enormous. So it is not uncommon for people to experience poorer body image during and after cancer treatment, but the impact with sex is enormous. So people with poorer body image are really impacted when it comes to sex and intimacy. They are far less likely to experience satisfactory levels of desire, but even arousal. So they can even have difficulty, people with poorer body image can have difficulty achieving orgasm. They're also more likely to experience unwanted pain. They're actually even though less likely to assert their wants and needs. This even includes sexual health needs. So people with poorer body image are actually less likely to request the use of condoms, for example, when they might want them. And they're certainly less likely to assert their pleasure-based needs, meaning they're actually less likely to experience pleasure and achieve orgasm, as I mentioned. So there's lots to consider here, and I want to, if we can move to the next slide, I want to shift now towards some really practical strategies. So the frame for us all here is this shift from, rather than returning to how things used to be, I want to get back to where I was, which is language I hear from my clients all the time. I want to return to something. We want to shift to this idea of exploration, of curiosity, learning a new body, learning a new sexual identity. So the role as healthcare providers is really around supporting this exploration and adaptation and fostering this real curiosity mindset. So let's get into some practical strategies. Let's go to the next slide. I've got 4 key takeaways for you all today. So the first one I really wanted everyone to think about, and I do a lot of work in this space as a supervisor, is really around clinician language and comfort, that there is no expectation to be an expert in sexual health, but with really lovely intentional language, you can really open the door and normalize the conversation. And I have to share, I'm really drawn to share that this is particularly close to my heart because my own father was diagnosed with prostate cancer last year, and he was also a newlywed at that time. He'd not long gotten married. And I didn't have a lot of conversations with my dad about his sex life. Fortunately, I didn't really fancy it. But I was very aware that the functioning and the erectile functioning was going to be important to him, particularly as a newlywed, a really happily in love newlywed. And as he went through his treatment, no one was asking him or even talking to him about erectile functioning at all. And it really only happened, as you can imagine, because I made him bring it up and ask those questions and ask those conversations. But I know what it would have meant for him to have been invited into that conversation rather than felt like he had to make that conversation happen. So this is what we're talking about when we're talking about inviting people into the conversation, really explicit permission. One of the biggest myths, and this is true across the board in healthcare, is that someone will raise an issue if they have one, and that is just simply not the case, but it is particularly not the case when it comes to sex. It is really the healthcare provider's responsibility to give that explicit permission. That, just a simple sentence like, many people find that this treatment affects how they feel about their body or how they experience their body in sex. Is that something you've noticed? Is that something you'd like to talk about? Is that something you'd like to know more about? These questions signal that I am a safe person to talk to about these things. More than that, actually, I want you to talk to me about those things. So explicit permission is really important. Desire is a really notable one that can really shift for people, how they experience their want for sex. Not uncommon for desire to be experienced more responsively. Responsive desire is that desire shows up not out of the blue, not out of thin air. It doesn't strike me over the head when I just suddenly feel like having sex. Responsive desire shows up when it's got something to show up for. And if your desire was normally accessed more easily, this can be a real shock for people and part of that identity shift. So this is all about clinicians working with people to not pathologize these things, to just really embrace them as like, this is all part of it. And there's lots to discover here and lots to work with. So this normalizing and inviting of language is really important. If we can go to the next slide. There is this lovely concept of pleasure mapping, which is about this very sensory, gentle exploration of the body and reconnection of the body. So clinicians can play a really lovely role here in a couple of different ways. Firstly, always, I know if you think you've heard me say curiosity too much, you haven't heard me say it enough yet. Like curiosity is going to be your guide. It's my guide with my clients to just foster curiosity, which is a really lovely way to frame up opportunity, opportunity to discover what might I like now? My body is different. What might feel good now? So I get people to do pleasure mapping by connecting to their senses. Very simple, the 5 senses, getting them to connect to each of the 5 senses and experiment and notice what they like. Part of this, when it comes to sex, is about the expansion of the sexual menu. So a sexual menu is all the things available to me when I think about what sex means. And something I talk about very openly is that in my own relationships, I've worked hard to cultivate such a broad sexual menu that I can always find something to say yes to, because the definition is so broad for me. It could just be flirting or reminiscing or kissing or cuddling or talking. If the only thing available to me is, 3 hours of swinging from the chandelier sex, I'm probably not going to say yes to that every day, right? Like I'm tired. No one's going to say yes to that every day. So we expand our sexual menu so that there's lots to discover and people feel like they've got things they can discover and say yes to. I have a tool for this, by the way. I have a yes, no, maybe list, which is a list of over 250 sex and sex adjacent activities. And it becomes like a game that people can play where they can explore what is something I would like to do or keep doing, what is something that is off the table for me for now, and what's something that maybe I need more information, but maybe I'd be open to that. And I get people to do this list with their partners as a really fun, sort of date night activity, really, to build language around what could we discover. I feel like we go on and on about this, but I'll pause there. I'm happy to take any of these conversations offline. Let's go to the next slide. I can't possibly leave you without talking briefly about the role of shame. Shame touches sex stuff for almost everyone. And when I think about this, an overlay body image and the body after cancer, people talk to me about feeling broken, feeling not sexual, feeling undeserving, unattractive, unwanted, unsexual. So it is really important to acknowledge that that might be here too, and that it doesn't need pathologizing. It actually makes sense. It's protective. It makes sense. So taking people through that as shame being part of the change process, and communication is going to be critical here. It is my absolute passion project. You might have heard in that very lovely introduction that I got from Tara that my research paper was all about the effectiveness of sexual communication, and it is one of the single biggest predictors of sexual satisfaction. So if I do nothing else with my clients, it is upskill them to talk about sex. So that is going to be a really important role for you as clinicians, to be supporting your clients to even put words to, which it takes me back to the sexual menu piece about expanding that sexual vocabulary. Now, the final kind of tool I want to leave you with is practical supports, really. So I could go on and on about this. I had to really kind of like rein myself in with this slide. These are a couple of products I recommend, but I could recommend a million more. But I just recommend knowing referral pathways as to this is for your own kind of course, this is wonderful for client treatment outcomes, but it will really bolster your confidence, of course, if you know that these referral pathways are available. One of the things I hear from clients all the time, every time I recommend a product or a referral pathway option, is that someone will say to me, like, I didn't know this was a thing, or I didn't know this existed. So I wanted to include this, not because I think you don't already know these things, but more because I wanted to highlight the role they play when it comes to sex is really normalizing for clients. Like, oh, these things really do exist. They are really out there. Hopefully I've done okay for time. The next slide is a summary kind of slide to summarize the last few points that I've made so that you've got it there in one page, although these slides will be available to you. The next slide is a book that I'm sure a lot of you are familiar with, but I wanted to just share, if you're not, Tess was an OT who also had cancer and who unfortunately recently passed away. I had the opportunity to present my research about sexual communication at the World Sexual Health Conference a couple of months ago, which was an enormous privilege, and a really big group of us, you know, from globally, from the sex education and sexual health space came together. And Tess was also due to present at that conference. And unfortunately, she passed away the day before the conference commenced. She just passed away that weekend prior. So this was a really sad moment for our community. And this book is, my presentation today has been deeply informed by Tess and her work. And if you forget everything I just said, that's okay, go and buy Tess's book. That would be my recommendation. But her work and this book is invaluable. That is it from me. The final slide just has my contact details. The example you can see on there is one page from my yes, no, maybe list. So that can kind of give you a feel for it. You can see it's like my yes, no, maybe list is divided into sections. This one is sensation and touch. And I also have a free downloadable on my website, this 30-day body confidence challenge. I just wanted to draw your attention to. You're welcome to connect with me in any of those ways. Or send my details on to anyone who you think would benefit from this. I feel like this, I could have gone for hours. I've done as best I can to get it into the time slot, but I hope it's been helpful. Thank you. Thank you so much for having me.
2 minutes to spare.
Okay, I'll breathe.
So if anybody has any questions, feel free to pop them in the chat.
Oh, yes.
It's allocated here. So in the meantime, while you're all busily buzzing away thinking of your questions, Laura, I just had one. With some of our patients and even some of the practitioners I've spoken to, one of the big barriers is people feeling confident to ask questions of people who may be older than them and trying to approach that in a respectful way. I'm just wondering if you could provide some example lines to introduce that, but maintaining that professionalism.
One of the biggest fears that I hear from healthcare providers is that they're going to offend or intrude upon, like that nobody wants to do that. And I really understand that. That's why I really like that language of just normalizing. Some people find that they experience X, Y, Z. Have you found that? Would you like to talk about that? Is that something you'd like to know more about? So that's starting that sentence with some people find, or people often find, or sometimes people tell me X, Y, Z, would you like to? Would you like to know more? Can I tell you more? And that gives people the opportunity to, of course, say no, thank you. But I have to add, this fear that you are going to offend or intrude upon is just, in my experience, the risk is negligible. It's really a very, very small risk if it's done with what I know you would all be doing in terms of, you know, the beautiful, professional, warm, empathetic, safe regard that you would all have. It's highly unlikely you're going to offend someone in that way.
Lovely. And then just flipping it for our younger patient population, where I guess historically lots of the education becomes more about fertility and reproduction and that sort of thing. Is there a way that you like to discuss sexual well-being and wellness separately to that?
Separately to fertility?
Yes.
It's a really great question. I mean, no, I mean, in some ways, no, because quite frankly, most of the sex that he's had in the world anyway is for pleasure. Like most of the sex that he's had globally is for pleasure, like most of the sex that people have. And I think that's actually quite important in some ways, not to separate the two. The only thing that's coming up for me though is, of course, the feeling that can come for people when they are experiencing fertility issues or trying to make a baby, and what shows up for them in terms of pressure and also body, like the relationship with the body is then disrupted. There's anger, there's resentment, or there's shame, or there's guilt. So that I think that would probably be actually something I have found I've needed to dial up now that I'm thinking about it, is probably that conversation more about relationship with your body. That if you are holding pressure, frustration, any of that stuff, if you're holding that, how that might interfere with our ability to access pleasure and be present for sex.
Thank you. And there's no questions in the chat yet, so I'm just going to keep fireballing at you until somebody else has something that they want to add. So I'm wondering if you can maybe talk us through, I know you had the slide there of some of the things on your yes, no, maybe list, but potentially how we could encourage a patient to initiate that conversation with their partner, and just sort of the other sorts of questions that you might have in that list.
Yeah, absolutely. So I have, when my yes, no, maybe list does come with some instructions at the start on how to do this, but I always talk to people who are new to sexual communication. If it's a topic they've not really addressed in their relationship, haven't talked to their partner about ever or for a really long time, I really encourage everyone to start from just a place of, checking for willingness and openness. So the first conversation with a partner about sex is ideally not going to be like a heavy sit down, turn the TV off, we need to talk about our sex life kind of, difficult conversation. That first one is just checking for willingness, which might be looking like, oh, I had this appointment today and they mentioned this, or I listened to this podcast and they talked about this. And it occurs to me, I would like us to have great sex for a really long time to come. I would like us to be great lovers for a really long time to come. I feel awkward, it feels clunky, but are you up for that? Are you up for us kind of talking about it a bit more? And that's kind of it. That would be it for the first conversation. So I think really, really just laying the groundwork for like, I would like for us to muddle through this together. And that's why I like the use of things like a yes, no, maybe list. External resources are my like favorite hack for sexual communication, right? That's why I love things like sharing blogs, articles, podcasts, those question card games, because then it becomes, rather than me sitting down looking my partner in the eye and saying, I'd like us to try a threesome. What do you think about us trying a threesome? Instead of that, I'm like, oh, there's a threesome on TV. What do you think? Would you like to try that? Have you ever done that? Is that something you want us to talk about more? Blame the external resources. I'm not asking the question. The yes, no, maybe list is asking a question. External resources take the pressure off. They're fun. You're allowed to gamify it. Anyway, I've gone about it. That's my thoughts on, yeah.
I think we've probably got one more question if we move on to the case study. So question from the crowd. How do you suggest we approach sexuality and sensuality topics with a person who doesn't have a partner, as these people often get missed?
Oh, yes, this is a great question. Absolutely. I mean, everything I've said today anyway starts with the self. So I like to really arm people with this, the pleasure mapping stuff I talked about, the connection to senses stuff, that starts with the self anyway. And that's where I would want people to start anyway. So I do get people to practice that. The other thing I highlight for people, and I kind of mentioned it briefly here, is that sexual activity, sexual behavior is actually only one very small part of our sexuality. Our sexuality is alive in lots of other areas of our life. It's alive in our imagination and in our energy and our eroticism and fantasy and masturbation and memories and daydreams and people who use toys or watch pornography or listen to erotica. Like, it's alive for us in lots of ways that don't involve another person. So I really appreciate this question, because I don't think I really highlighted that today, but that is how I would highlight it, is that partnered sex is actually a relatively small part of how our sexuality is experienced.
Perfect. Thank you so much.
Thank you. Thanks.
So we are going to move on to a case study now that the lovely Lisa is going to present. So Lisa, if you want to start share screening while I do your introduction, that would be amazing. So Lisa Carson has worked in cancer care for over 15 years, with roles including radiotherapy, chemotherapy, specialist cancer nursing, and project work with communities of refugee background. She has worked as a McGrath breast care nurse since 2021, providing holistic care for patients across the span and of their cancer experience, including support with sexual issues experienced as a result of cancer. And might I just say, one of the most lovely people that I have ever met. So please welcome Lisa.
Thank you, Tara, for the very lovely intro. Hello, everybody. My talk today is quite brief. I do just want to say thank you so much, Laura. That was incredible. And I feel like if I had seen your presentation before I had this encounter that I'm going to present today, I feel like I would have probably been able to help this woman a bit better than I was able to. That was really wonderful, and you've given us some really concrete kind of things that we can take away as clinicians and use. So thank you so much. That was very valuable. So I'm going to talk today about an encounter that I had with a patient in recent times. So I am a McGrath breast nurse at Bendigo Health, and one of our one issue that's really common for our breast patients is sexual issues. So we do a little bit of work in that area. By no means am I an expert. I do my best, and I will share you today kind of how I've managed in this situation. The picture that I've chosen there, I chose that really deliberately. It actually took me ages and ages to find the picture that I was happy with, and I really thought that this was a great image, because when people are having cancer treatment, like Laura mentioned, it's all about side effects, it's all about your medical stuff and what's going on. And that's all the day-to-day, and that's what's talked about all the time. And with sexual health, it just seems to be something that just kind of fades away in the background and is often not addressed. And I thought that this picture was a really good representation of that. So here's my click-through page. So this slide is really just about the common issues that we see with patients with breast cancer. So breast cancer patients, they have a certain set of chemotherapy treatments, hormonal treatments, radiotherapy. They all tend to have, the same, essentially the same pathway. Not everyone goes through all the steps of the pathway. Surgery, to breasts, to reproductive organs, hormonal blockers that that mess with estrogen levels, chemotherapy that comes with all the side effects of that, and radiotherapy as well. So we're really used to seeing these kinds of side effects, and these are, a lot of these side effects directly have an impact on people's sexuality and sexual function. So that's just a bit of a context of the patients that I'm used to dealing with in this role. The lady that the case study is about today is actually not a breast cancer patient. So in addition to my breast work, I do also have worked and still do a little bit in chemotherapy. And our the breast nurses here at Bendigo Health have really been encouraging. We really encourage all the practitioners that we interact with to be talking about these things, raising these things. And in recent times, they've really been doing really well at that. And so we've been getting a lot of doctors coming to us and saying, I asked the question and they said yes, and they made the point of saying, every time I ask the question, the answer is yes. They're kind of realizing that now that they're starting to get into the habit. And so we're getting a lot of requests to talk to our patients about these things because the topic's been raised in the doctor's appointment, which is great. This particular woman was not a breast patient. She was a lady with lymphoma, and one of the doctors said, we've identified that she's been having these sexual difficulties. Do you mind talking to her even though she's not a breast patient? And I said, of course I will. So it just so happened that I was working a day in chemotherapy and I happened to be looking after this woman. So that was the context in which we had our chat. So just a little bit of an overview of the patient that we're talking about. She was a young woman, fit and healthy in her normal life. She had a lovely partner who was supportive and communicative with her. She had an active job and hobbies, and generally fit and healthy, active lifestyle. So she was diagnosed with a Hodgkin lymphoma. She started on some chemo. She wasn't doing terribly well on that, so it was changed to a different regime. And along with her chemo, she was also having Zoladex injections, which was for her ovarian protection. So if anyone here is not aware, it, in a nutshell, kind of turns off ovarian function to protect that function during chemotherapy. And then later on, when treatment's finished, that treatment can be stopped if people are wanting to try for pregnancies later on. She had a pretty normal experience with common side effects throughout chemotherapy. And she was well supported with a lot of the supports that we do have available for people on cancer treatments. Sometimes people decline a lot of the supports. This woman did make use of them, which was wonderful, and she was linked in with a whole bunch of supports during her treatment. So I was looking after her for chemo this day, and I said to her that who was her nurse practitioner actually, had a chat about this, asked me to talk to her about it, and she was happy for us to have that chat. So with my background and the issues that are normally kind of in my mind when I'm thinking about sexual dysfunction, I started to go through the list. So she's on her Zoladex, so I'm expecting she's having menopausal symptoms. She said, no, not really. That haven't really been having flushes, haven't really been having general menopausal symptoms. So I went a bit deeper. Sometimes people don't associate vaginal changes with that. I said, are you having any dryness, any itchiness, discomfort? No, that's not really a problem. How about libido? She said, my libido is less than normal, but it's still there. I'm still wanting to have sex. I'm wanting to engage in this, in sexual activities, which is causing the problem because I've got this barrier. Mood wasn't really a problem. She's on chemo. Obviously, she's struggling, but she was managing okay. She was linked in with all those supports. Her body image wasn't really a problem, she said. She had lost her hair with chemo. She wasn't too phased about that. And her fatigue was there, but, again, she was engaging in exercise support. That wasn't really the contributing factor. So by the time we got to the end of my list, I was a little bit, what else is there? What's going on here? And so what she told me, that her barriers were really more internal, and they were psychological things, not these physical things that I, as a breast nurse, am really used to dealing with. So for this lady, she kind of had two aspects to it. So for one, she was worried about the effects of chemotherapy, and she was unclear about the recommendations around the timeframes about having sex after you've had a chemotherapy. she said it was touched on early on, but she'd, forgotten it or wasn't really clear on it. And so she didn't feel confident in when was okay and when was not okay. Then the other aspect to it was she said she had this feeling of being dirty. She was on chemo, which is a systemic treatment. It's all through your body. And she just had this feeling that she was dirty and she didn't want to kind of contaminate her partner. So that was where she was coming from. So this is essentially the discussion points that I had with her, which, as I said, not an expert, just doing the best I had with my knowledge. So the first thing I did was go back to that education on chemo safety and make sure that she was clear with what the guidelines are. And in a nutshell, so chemotherapies have different half-lives, which means they stay in your body for various amounts of time before they, get expelled through bodily fluids. They do have different lengths of time that they do that. So as a broad guideline, we say 1 week after chemo, don't exchange bodily fluids. After that time, it's essentially out of your body and that's okay to go ahead. We made that clear. I really encouraged her to talk to her partner about these things. So they hadn't really talked about it very much. It was kind of a thing that was sitting with her and she didn't really know where it was coming from or how to talk about it.
Let me check. It'll be on one of these.
Someone's just got their microphone on there. I talked about, and this is kind of, this is very much what Laura was talking about. So, but obviously that body mapping is like such a great way to approach it. I talked to her about identifying, really kind of reflecting and figuring out what is it around the sexual activities that they've tried or wanted to try that made her feel comfortable or not comfortable, trying to define what those things are and sharing those with her partner. Considering other options, not just penetrative sex being the be all and end all, other kinds of activity, less intimate, less physical, intimacy, and different kinds of touch. We talked about the idea of parallel play. So if she was not feeling comfortable with her partner touching her or touching her partner, for them to be still engaging in sexual activity together, but not necessarily, on each other, but more self-stimulation and sharing that experience. Use of appropriate lubricants. And I was able to supply her with some further reading and some resources to go to. So there were some booklets and some pamphlets that I was able to give her, as well as directing her to some online resources. And then encouraging her to discuss it further with a specialist, a sex specialist, or she was linked in with a psychologist as well. She hadn't talked about these things with them, so I encouraged her to do that. So I did give her a call a little while ago. I wanted to ask her permission about using her story for today, and also to follow up and see how she had gone. And she has finished chemo by now, but I really just wanted her feedback on how that interaction went. It was just a one-off interaction that I had with her. She said that after that chat, she really felt empowered to go back and talk about it with her partner, and that she felt like she knew what to say. She felt more confident in, in the chemo safety aspect about when was okay and when was not, to be having that more intimate contact. And then together they were able to plan more what they were going to do and to be able to work around those challenges for her. So she said that it was a really good outcome. So I guess that little experience just raised a couple of points and questions, which is the last little part of my slide here. The first was that she was able to, I was able to have that chat with her, which led her to being in a better place sexually afterwards, which was great. That was a really good thing. It was a good outcome for her. If that nurse practitioner hadn't had that chat with her, hadn't had the confidence to ask those questions, they would have struggled the whole way along. And my lovely colleague Rosie here, who's sitting out of the camera, who is also one of our McGrath breast nurses, when we were talking about leading up, and sorry, Rosie, to steal your story.
No.
I'm going to share it.
Yeah.
She was saying that she was having a conversation with one of her patients who is a metastatic patient, and kind of talking about the time when she was earlier on treatment with her partner. And Rosie raised the issue of sexual difficulties, and it was, or do you want to say it yourself? Or do you want me to?
So doing as, sorry. In doing a supportive screening tool, she answered no, and always was her take was she was very independent, so she was very hard to engage in a conversation. But just a more recent conversation was she's now a widow, but she was remembering back to that she just completely lost her libido, and the response was that her partner was angry, and he said, well, you get what you want, but I don't get what I want. And of course I just reflected in my role about how I could have done that better. It just makes you think about, did I provide enough opportunities? But often she was out the door or didn't want me calling, or do you know what I mean? It's kind of that fine balance.
But you're not the only one looking after that woman.
Oh, no,
there's a whole range of people.
But in reflective practice, and this is what this is about in trying to,
and I just, hearing that story from Rosie just made me reflect, maybe, who knows how many of those situations are going on where the question's not being answered, the things aren't being addressed in the relationship, and it goes on to be an awful time where, in this case, the nurse practitioner asked the question, he started the conversation, which then translated into that continuing on at home, and then being able to figure out what they needed. So just that reminder that it's just, starting that process is so essential. For me, it was a really big reminder and kind of wake up call that it's just not all about those physical things, which for, as I said, like for our patients, a lot of it is physical. So it was a really good reminder for me that it's just not all about the physical body, as Laura, went into as well, which was really, really helpful to hear. And I guess also just raising that question, those doctors are asking those questions because they're being, they're starting to feel confident in doing that, but they're feeling confident because they know they're going to send them to the breast nurse to go into it. And if they didn't have us here, or if someone doesn't have someone who they know can carry on that conversation with, what's happening then if they ask the question, the person says, yes, I've got some issues, and they don't have an answer, then that's just such a big barrier. So that was just another, I guess, question that it raised for me. And that's the end of my presentation.
Amazing. And well done, Lise. There's a lot of love for you in the chat at the moment. So well done.
Thank you.
I think you've done a really excellent job working with that patient, and as you said, sort of raising it. We've got a question open to the floor. Have you noticed any trends or patterns in experience with certain cultures, and how have you addressed these? So I guess this is open to Lisa and Laura, if anybody wants to jump in.
I haven't really got anything of much use as an answer, to be honest. I've got to say, on reflection, the patients that I've had these conversations with have been pretty Anglo English speaking. I don't think I've ever had a conversation about sexuality with anyone who was from a more culturally or linguistically diverse background. Of you, Rosie? No. And I wonder whether that's, again, something often when we've got people with language barriers, it can be such an effort to get the essential information across about cancer that a lot of those other external things are quite potentially not getting, we're not getting to those things.
Laura, have you got anything to add to that?
Yeah, absolutely. I could do a whole separate session on cultural competence and culturally competent practice. But one thing I would add is this is where our own kind of reflective and reflexive practice will be really important to consider what we might be bringing into the room. And a really obvious example that I think of is, the research that I did about sexual communication. I personally might think the more the merrier when it comes to sexual communication, right? I might personally have that view and think this is really good to be talking with our partners and with our healthcare providers about sex. But actually, the research I did found that that wasn't always the case, and that when participants from different research studies were from culturally and linguistically diverse backgrounds, how they appraised effective sexual communication really differed. So I might hold a view that it's good to talk about sex early in a relationship. There are certain cultures and ethnic groups who wouldn't share that view, and that sexual communication at that early stage in the relationship would be unwanted or inappropriate. So it's not my job to teach everyone to talk about sex early in the relationship, right? It's my job to help clients meet clients where they're at and upskill them in ways that are going to be meaningfully beneficial to them.
Yeah, that's just kind of triggered a bit of a comment from me as well. In my other role, which is working on improvements for inclusive access for our refugee communities here in Bendigo. Our two main communities here are Karen from Thailand, Burma, and people from Afghanistan. And when we have been looking at doing focus groups and education sessions for those groups, they're very different in their cultural practices, and even in that Afghanistan, the people from Afghanistan, in those groups, we have to hold different sessions about, even education sessions for the men and the women. The men wouldn't come to the breast cancer one. In some cultures, that separation between men and women is such an integral part of that culture that even talking about these things, or the idea of bringing up those things, is potentially just such a different way that it really I guess it's just something to think about, that the way that we value that communication and the way that sexual relationships function, is not the same for everybody. And how do we get about it? Maybe it's more about talking about someone's individual sexuality and how a person can feel comfortable in their own sexuality without necessarily involving their partner in that conversation. Perhaps, I don't know.
And I think just coming from the chat as well, there was a comment that normalising that celibacy after treatment and that sort of thing is normal and a side effect as well. Laura, do you have anything to comment on that and how we can have that conversation with our patients?
Yeah, again, I think it's probably just an extension of the answer I gave to the last question, which again, I don't ever frame my job up as like, how can I help people have more sex, have sex all the time, talk about sex that is absolutely not my goal here. So, but someone who is celibate still has a sexuality. So I think that's still really important to bring curiosity to, but to help people work towards experiencing their sexuality, however it is being experienced and expressed for them at the moment, in ways that are meaningful to them. So if that involves no partnered sexual activity or no sexual activity of any kind, my goal is to help that person to experience that with joy and meaning as well. I'll leave it at that. But yeah, it's very similar to the answer I gave about culturally competent practice for sure.
Amazing. Thank you both. We've just got another couple of minutes, so if anyone's got some burning questions, feel free to pop them in the chat or just pop your mic on and ask away. As I said, we've got another couple of minutes, and then Krista's just going to come in and pull everything together and finish up for us. So
Oh, alrighty. I might jump in here. Oh, can I just say this has been a fantastic session. Thank you so much, Laura and Lisa, for your really heartfelt and as Sophia said in the comment, why can't these discussions be framed more in love and kindness? And you both have exhibited that in your presentations. I really love people to enter their opinions and ideas on the Survey Monkey. There's a QR code and a link there, because all the feedback that we're getting sort of shapes the next session and also the future of this community of practice. So to add value and also your voice, please do that. For the summary, I guess I think the importance that you pointed out, Laura, particularly in regards to shame and the shame that we already bring with us, both as clinicians and our IC responses and where we're sitting in the room, and the shame that society already places on us about our bodies and about our sexuality. And then you layer that with the toxicity of the treatment and the changes, is something that really is a very powerful thing, and also shouldn't be framed in a negative way. It's a very real reaction and an understandable reaction, and that allowing time for the grief of these changes and what was past, but then also having that curiosity for the future. Even a small thing like, which is also something that Tess mentions in her book, it's a fantastic book, is like even just wearing something that feels nice and silky on the skin can be a little bit a way of touch, getting your sensation of your sexual self back, and small things like that just even add to the day-to-day of building it up again. So the next community of practice is going to be in March, and the focus is going to be on penile rehab. We're really hoping have lined up with Victoria Cullen, who's the touchy subject psychologist, who have really focuses on that. So what I'm putting it to the team of everyone out there who's on screen at the moment. I'd really love a case presentation about male sexuality in particular, and if it's linked with penile rehab or prostate cancer or urology, that'd be fantastic. So get your thinking hats on. Maybe if you want to do it, a few of you working together on it, and please get in touch with me or via my my website, my email, or via the LMICS email. That'd be fantastic. So otherwise I'll be chasing people probably early January, Feb, if anyone's around. So again, thank you so much to Laura and to Lisa and to Tara too for managing the coordination so very well and doing such a beautiful introduction, and those questions were great. And thank you so much for everyone online. There was a lot that we could have covered, and I'm glad, like looking at the chats, it's been really interesting and some great discussions and learning from each other within that as well. So yeah, I don't know if anyone else has got any final comment. I'm just all hope you're doing the survey. Thank you.
So as Krista said, we've only got another couple of minutes, so if anyone's got any burning desires, feel free to pop it in the chat or turn your mics on. Otherwise, hope to see you all in March.
Thank you.
Bye.
Bye.
Thanks, everybody.
Thanks.